Good afternoon, and welcome to today's webinar titled Enhance Patient Safety and Simplify Clinical Workflow with Smart Connected Technology, presented by Healthcare Innovation. My name is David Rath, and I'm a senior contributing editor for Healthcare Innovation. And we'll be hearing today from Dave Lively and Rochelle Magness of Vocera as they discuss how a unified clinical communication platform with intelligent middleware enhances patient safety and improves clinical workflow. Today's program is sponsored by Vocera, and thanks to our sponsor and to our audience for giving us your time and attention today. And before we get started, we have a few housekeeping details. To submit a question, please use the Q&A box to the left of the video window at any time. You don't have to wait till the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. And finally, you can join us on Twitter. You can tweet using the hashtag HILiveWebinar. So at this time, I'm going to turn it over to Rochelle to begin the presentation.
Thanks, David. So I want to start this morning by talking about the challenges that arise in today's clinical communication environment. These are the challenges that I discuss with clinicians on a daily basis, with system administrators and IT professionals. And ultimately, these are the challenges I faced as a clinician when I worked at a busy hospital. Today's clinical communication environment lacks a central control. Clinicians receive alerts from a variety of places, and there's many devices that cause numerous alarms. There's different ways to text message or instant message the different clinicians, and nurses and doctors today still use desk phones, cell phones, and even pagers. All of this creates a very noisy care environment and contributes to information overload and ultimately alarm fatigue. This leads to delays in responses and delays in patient care. I want to describe a story to you of how I explain this concept and this problem to my husband, family members, or even to my previous hospital board. Think of your most important work item that you're working on right now, whether it's a report or whatever you do for work. And then I'm going to turn on all these beeping alarms behind you. I'm going to send you multiple text messages. I'm going to have someone call you on your cell phone and on your desk phone, and someone just walked into your office. This basically describes what it can be like in a very chaotic clinical environment. It's no wonder that this type of care environment can lead to patient risks. So how do we get to that patient harm state? It's usually because all of these factors become compounded. So information is siloed, and as a clinician, I have to go search for it. Multiple alarms are causing me to have alarm fatigue. I'm getting all of those interruptions, whether it's from a phone or someone needing to talk to me or from an alarm. And these contribute to very inefficient workflows that take a lot of time for me to do simple tasks. I then am getting interrupted and have potential for medical errors, and that ultimately can lead to the risk and harm to the patient. So how, as IT professionals, do we help support our clinicians and create less of a chaotic environment? As we talk today, I want you to think about the information and how it's designed in your hospital. Is your information interoperable? Is it easily accessible for a clinician? Or is it in silos? Do you have to go to different places to get it? And would you like the information to be more interoperable? I think of interoperability like a cul-de-sac. When information is siloed, it's basically stuck in a dead-end street. How can we get the information out of the dead-end street? I'll let Dave talk to you about the technical barriers that are usually in place that keep this information stuck and that contribute to a fragmented clinical communication model.
Thanks, Rochelle. And this is key. If we want to think about how do we get out of that cul-de-sac, we have to think about what's keeping us there or what's going to sort of funnel us into that a point. And as Rochelle talked about, data silos are probably one of the big ones. And when you think about the hospital, you may have one system that's set up for setting alarms from a particular patient monitor. You may have another system that's got all your patient records in, your electronic healthcare records. You may have another system that's doing your nurse assignment. You may have yet another system that is doing your physician on call. And all of these are silos where the data and communication happens within that silo, but it doesn't necessarily cross. And this ultimately creates all those burdens for care teams that Rochelle just talked about. Security is often also a concern, which is how do I make sure that private health information stays private and my data stays private? Increasingly, and unfortunately, hospitals are among the most at risk to ransomware attacks and other attacks by bad actors. And so security of all of this data is paramount. We also always have to think about time and cost. No one has unlimited budgets. No one has unlimited people. So we have to think about how do we find the right solutions that we can put together that can start to bridge these silos, provide the security we want, but do it such that I can implement it in the timeframes I need and at a cost that fit within my budget. All the while, by the way, figuring out how do we deal with legacy systems? Because one thing that we learn here in technology is just because technology can make a workflow better in the sort of the minds of the technology doesn't mean it's actually better from the standard point of view of those who use it on a daily basis. When you get really entrenched in your workflows and here's how I use the phone, and I know that this extension always gets me this particular role, or this pager is always for that on-call person, et cetera. As overwhelmed as everyone in healthcare on the front lines are today with all of those alarms and beeps and calls and everything coming out all at once, the challenge of how do you enable technology to make that easier, but not sort of a step too far? How do you bridge from those legacy systems is really important to think about, because our mental memory is really set up around how we use those systems. And then finally, technology is great, but standardization presents a problem as well. And that there's a lot of different protocols, and I'll talk about some here in a few slides. We've got protocols in healthcare that go back to the early days of paging. And healthcare is about the only market that still uses some of these old protocols. And so they do provide some standards, but as different vendors move forward on the technology side and they move forward maybe at their own pace and their own systems, it also creates a pretty siloed and fragmented market where there's a lot of different protocols and systems that we have to think about. And so the solution for all of this is really, how do we think about one platform that integrates all of these, that touches all of these different silos that exist in a hospital, that connects everyone on the care team with all of the different devices and systems that are generating some amount of information? Because that's another trend that we see in healthcare today is everything is getting smart, everything is getting connected. Every system these days coming out from vendors that you're going to deploy into a hospital, it's got some sort of smart technology built into it. It's getting connected to the Wi-Fi network, or it's getting connected to 5G, and it's all got information that needs to get to somewhere. And so how do we take all of this information that's coming from all these different systems, devices, how do we integrate it with the clinical systems, with the operational systems, and then apply some intelligence on top of it to really help to optimize those resources and make sure that we can get the right information to the right people so that we can improve response times. So Rochelle, why don't you talk to us a little bit about the framework that Vocera is putting together around all of this?
Sure. So Vocera's approach is that we really want to take it from, as Dave said, a smart framework we approach clinical communications as a modular platform. So we could go into a lot of details, and there's a lot of information on this slide, but today our focus is really the Engage Intelligent Workflow Engine, which is the gray square box on this slide. It's the backbone of the SMART framework, and it's what works behind the scenes to connect those devices that you may be looking at connecting. And it's what can help hospitals make that more interoperability actually function. So it can help connect the EHR, the nurse call system, the patient monitoring system, and ultimately it delivers alerts, alarms, notifications, messages to any type of end device, whether it's one of Vocera's badges or a third-party smartphone application or information on a desktop computer or even those legacy systems like pagers. It is device agnostic. So let's take a look and go a little bit deeper into that smart insight layer. What makes Engage work? Well, I like to describe it like an iceberg. At the tip of the iceberg is basically this comprehensive view of the patient. It's what the clinician sees. It's what I want to see as a nurse. It's what's going on with my patient, whether it's an alert, what room they're in, their date of birth, what allergies they have. It's that glimpse of what's happening at the patient level. What goes on underneath it is where we like to say the magic happens. And it's also where a lot of the work can go into for IT professionals. And so the Engage Insight layer actually works smarter for IT, and it is the foundation for interoperability. It is able to scale and unify the staff assignment for the clinicians, but also all of those different systems for the IT individuals. It's an intelligent workflow engine that's FDA 510K regulated, so it can send alarms from cardiac monitoring systems, ventilators, IV pumps. And it's also, as Dave mentioned, vendor agnostic with over 150 different integrations or workflows. So I'll let Dave go a little bit deeper into some of those integrations.
Thanks. I'm going to skip forward one slide. I'm going to come back to this one because I want to build on that 150 integrations that Rochelle talked about. And this goes back to helping to break down those silos in the hospital. We've done over 150 different integrations with systems across the entire breadth of healthcare. As you can see, over a dozen different nurse call systems, various patient monitors and other medical devices, obviously the electronic healthcare record systems, because that's where we start to pull in context to provide that comprehensive view of the patient, start to associate it with these other systems. We can start to then combine information from these systems. And so, you could get a nurse call alert that pulls in context from the EHR and then also has information from real-time location system that you might have deployed in your hospital. So we can start to pull all of this information together to, again, provide that additional context around what's happening and really give the care team the information they need to be able to take action on some of these communications that are coming in. Real-time location can also help us do interesting things like don't send an alarm if someone's not near the patient room. And as Rochelle talked about, it's a really loud, chaotic, noisy environment. And I like to say that the notifications and alarms that you don't send can often be as important as those that you do, because if everything is being sent and everything's coming at you, it's almost like you're listening to nothing. It's really easy to get overwhelmed with all of this. And so you tie the data together from the various systems and the monitors, you tie it with location data, you tie it with context, you tie it in with staff assignment and call scheduling. And so we know where the data is coming from. We know what patient it's associated with. We know who's on the care team for that patient. And then beyond just who's on the care team, we know who's available now that can take action, or who's available that's closest that can take action. So a tremendous amount of breadth available across the ecosystem. If we haven't integrated with it at Vocera, we probably have an existing protocol that can, or we probably have a model that is really similar to what the new system is going to do. We're adding usually one or two new integrations every quarter as we work with our partners in the healthcare system to bring more connectivity across all of this. And to think about it from kind of an IT and a technical standpoint, you can think of, all those different 150 systems. It's not 150 protocols. There are probably half a dozen or so pseudo standard protocols. Sometimes they're actual industry standards, things like HL7. Sometimes they're more a de facto standard that multiple vendors have all come together and agreed on. We're going to use this protocol, but it really does run the gamut. HL7 is pretty ubiquitous out there in terms of integrating with electronic healthcare record systems or patient monitors, devices, lab systems, things like that. It's probably the most common protocol that we run across. FHIR, which is, think about it as the more modern sort of replacement for HL7. It's just starting to come into to play. It's been out as a standard, but in terms of actual implementation, we see very little of it thus far. There's some old sort of paging and voice protocols, things like SIP and TAP and WCTP that, even though they're old, they do implement the standard that gets used across healthcare with a lot of these different devices. And then, as I showed, a lot of those vendors, nurse call, things like that, there's a lot of proprietary protocols that exist there as well. Rollin has its own set of protocols and interfaces, just as one example. And so while there may be, half a dozen or maybe as many as a dozen standardized protocols, there's at least that many, if not more, that are proprietary protocols for specific vendors. So it can be kind of a mess in terms of the protocols that we use to get information, as well as even the protocols that we use to then disseminate that information to various endpoints. And in terms of the outputs and on how that communication gets out to the care team or gets out to those other systems, we can send it obviously to our own devices, but we can send it to a plethora of third-party devices as well, using various standard-based protocols. And so, to help make this a little bit more real, I'm going to hand it back to Rochelle to talk a little bit about the flow and some examples of those, alarms and notifications coming into the system.
Thanks, Dave. So let's talk about how does the data flow through the intelligent workflow engine. This diagram shows the various stages that data flows once it hits engage. We have to first start with those inputs Dave talked about. So whether it's a physiological monitor or the nurse call system or a mass notification, the incoming integrations send data through filters where Engage decides what is needed. Next, the data gets passed and filtered and stored into a database. As additional events come into the system, the data stored is evaluated to see if anything is actionable. And that goes back to what Dave mentioned. Not sending an alert is just as important as sending one. So once that data is evaluated, which we're at the magnifying step here on this diagram, if an event is determined actionable, Engage starts to connect those pieces together. I think of it like a puzzle. Engage says this alarm and this data point and connects those two. An example would be a nurse call alert. We can pull information from the EHR, like the fall risk status, and also the patient's name, location, date of birth, potentially allergies, maybe recent medications, whatever is important to the clinicians related to that alert. And we combine that with staff assignment from a variety of systems to deliver that nurse call alert, whether it's a bed exit or a pain request, to the appropriate caregiver. Once that data is combined, so we're at the puzzle piece step here, the delivery is initiated based on predefined rules. Those predefined rules can have multiple escalations. So if the nurse is busy, it can go to her charge nurse or to a buddy nurse. The delivery then occurs based on outgoing adapters and integrations to a device of your choice, whether it's a Vocera badge or another application. So what does that mean? That basically means that we can help manage cognitive load. The Engage system filters, prioritizes, escalates, documents, logs, and also has reporting insights. Those filters are one of the key points of the intelligent rules engine. It allows for patient self-correction so that not every alarm is sent to the clinician. It's also customizable based on hospital protocols. It also helps to prioritize. What's more important, a cardiac alarm, the nurse call alert, a phone call? The system can help prioritize that in a clinician's inbox based on hospital standards. It then allows for those escalations. An alert going to a pager may only go to one place. With the intelligent workflow engine, if no one answers that alert, or if I'm a clinician and I'm busy, it can go to someone who's more readily available. So it helps decrease that cognitive burden and that chaotic interruption that happens. The logging capability can really help the IT and technical teams because it gives traceability into who accepted the alert, who declined the alert, was the alert delivered to the appropriate place, and at what times. And then ultimately, the data analytics can provide insights. Who's an alarm flood? Which clinician may need more help or support? Let's use the data to drive those decisions to help make those workflows even better. So let's take a look at an example. Here's a bed exit. Patient's getting out of bed, the bed exit alarm is alarming. The nurse, indicated by the circle here and the red dot, is busy. She's in the medication room and she's unable to, or she shouldn't be interrupted because she's drawing up important medications. The intelligent workflow engine knows that she is on do not disturb, so it bypasses that nurse and sends it to another available nurse, whether it's a nurse outside the patient's room or the charge nurse. The intelligent workflow engage can combine information from an RTLS system, the EHR, and the nurse call system so that that clinician gets filtered, prioritized, and routed alerts to the appropriate clinicians in real time. So let's go one layer deeper. That's what the clinician sees. How did we get there? Well, the configuration part is actually in your hands as an IT or system administrator. We try to make a very simplified UI called the Engage rules. This allows you to actually go in and configure a bed exit. You would choose the alerts based off of your hospital policies and your clinician recommendations, and you would set up for an active alert. It's bed exit. And what escalation path would you like? Who do you want that to go to? I want it to go to the nurse every time. If the nurse is unavailable, go to the nurse buddy. If the nurse buddy is unavailable, I want it to go to, the team or the department unit level. Depends on the alert and the severity. All of this can be customized as specific to different departments or as standardized as the hospital would like. Most of the time, I want a standard across multiple med-surg floors, but what works on a med-surg floor may not work in an emergency department. And all of this is very configurable, but also can be standardized. So I'm going to pass it back to Dave to show how the Engage rules helps remove those barriers that we talked about at the beginning.
Thanks, Rochelle. And like I said, there's a lot of barriers that have come into play on things that stop you from really taking advantage of all the capabilities that you have in your hospital. These silos are one of the biggest challenges that people run into because all these different systems, they don't talk to each other. And so by being able to sit in the middle and integrate the on-call schedules with the nurse assignments, with the information coming from patient monitors, which might be associated with the bed, to the care team information that may be coming from your electronic healthcare records that have other physicians and members of the care team, to location systems, to your phone system, to maybe departments inside your hospital that don't have a mobilized strategy and they're more sitting in place at their desk and they have desk phones, to even members of the sort of the extended care team, such as patients and family that may be outside of the hospital. How do we start to bring all of these silos together, do it in a secure way so that we're not exposing any unneeded data to people who shouldn't be able to have access to that data? This is how we start to truly enable the smart and connected healthcare system that everyone is on the path towards deploying. We also can't afford for this to take 3 years and $18 million to deploy, because we need to take advantage of these systems now. And so again, it goes back to those integrations how can we work with what you already have deployed? Rather than force a new directory for this system, how do we integrate, for example, with your Active Directory system so that we can dynamically sync that information over? How do we apply single sign-on and consistent user identities so that you don't even need to have a separate identity with username and password for this system, that we could use your identity from your EHR, for example, or if you have a sort of common authentication system from someone like Imprivata, we can tie into it for authentication into the system. And so anything that we can do where we can integrate with your existing systems on the IT side, whether it's your directory or your authentication or your phone system, et cetera, those are all things that lower the barriers. They help connect the silos, but they also lower the barriers around cost and time that are associated with all of this. And then legacy systems. And people like Rochelle are constantly reminding me that we really need to help hospitals modernize, but we can't sort of snap our fingers and have them go from one system to something that works completely differently. And you need this unified experience that takes advantage of the existing directory services you have, your existing telephony services, your existing network infrastructure, so that we can bring people into a more modern solution, but do it without taking them sort of too far from a technology perspective, forcing them to learn completely new ways of doing things. And then finally, on the standardization side, I talked about the protocols that we support here at Vocera with engaged standards such as HL7 and WCTP, but even proprietary vendor-specific protocols. It's a challenge that there's fewer standards out there, but that's one of the reasons why we've done over 150 different integrations as well, is to help you overcome that lack of standardization, because we've gone and done the hard work of integrating to those various proprietary protocols and then bridging those proprietary systems over to more standards-based systems. Rochelle talked about how this system is FDA 510K Class 2. We're also regulated in Canada, in Australia, in Great Britain as well. So depending upon where you're at, we're working with the local and national health departments so that you can get not only the integrations, notifications from non-regulated devices, but also all of those regulated medical devices, such as patient monitors, cardiac monitors, et cetera. So to help, again, make this a little bit more real, I'm going to hand it back to Rochelle to talk about a use case and example of someone that's using this.
Thanks, Dave. So yes, I had the opportunity to work with a hospital in Southern California regarding a challenge they had for their cardiac monitoring telemetry system around their war room. They had issues where they couldn't easily communicate from the war room to the staff on the floors. They would either have to, if they were on the same floor, yell, or they would have to use phones. And if the nurse was unavailable, it would just ring and ring or roll back over to the main central station. This led to a lot of missed alarms, delays in care. And so they were really looking for a solution to this workflow problem. So we not only sat down and mapped out kind of what their goals were and what data they had, but we also really wanted to address the problem. And so to address the problem, we introduced them to the Engage Intelligent Workflow Engine, and putting those alerts and alarms through the engine, we were able to actually decrease the number of steps that the monitor tech had to take from 8 steps to 3 steps. 3 steps which saved time and improved efficiency, that got that alert from the cardiac monitoring system to the nurse in real time. And it not only just got them the alert, but before they would have a phone call that said, your patient's in VTAC. Well, as a nurse, I didn't really have a lot of other information for them to look at. This alert on, they used iPhones, they actually got a lot of other patient contextual information, including the waveform, the last set of vital signs, the last lab values, so they could make clinical decisions and start thinking about what is going on with that patient as they were headed to that patient's room. The intelligent rules engine also was able to filter out a lot of the nuisance alarms that they were being forced to send previously. And so they were able to actually reduce the number of nuisance alarms by about 90%. And ultimately, the goal was to close the loop of communication. They wanted to see from start to finish that an alarm from the cardiac monitor was delivered to the appropriate caregiver at the right time. And so with the documentation and the logs that we talked about previously, the rules engine is able to deliver that. And so I hope that you saw, based on the real world example and the information we provided today, I'm going to circle back to our cul-de-sac example, that the intelligent workflow engine can really get your information out of that cul-de-sac. It can get it from being stuck and get you on the interoperability highway and connect a lot of your different medical devices or nurse call systems that are siloed today and make them interoperable. I'll pass it back to David so that we can take on questions.
Yeah, thanks, Rochelle. We do have some questions here. Let's see. One is, does the Engage Intelligent Workflow Engage Rules configuration override escalation that may be set up in Roland R, the person asks?
I can take that. No, it does not. So that's ultimately a choice up to the customer, whether you want the escalations or the rules to live within the nurse call system, in this example, Roland, or within Engage's intelligent workflow engine. There are pros and cons. Ideally, by putting all of your devices and alerts and alarms into the intelligent workflow engine, Engage can actually pull those different pieces of information and then prioritize the alerts and send them to the appropriate caregivers. We can still do it as a pass-through, but you lose a lot of the complete patient context when you take those escalations out of Engage.
Yeah, and that's the one thing I'd add to that, Rochelle, is we can support it either way. If you're handling and doing all the escalations within Roland, then you can just pass through. But then you might miss some of those opportunities where you've now got Roland doing its own escalation to a particular person, but that person may also be receiving monitor alerts or alarms from other systems. And so, if you're doing all of the escalation within our system and taking into account presence, whether they're in do not disturb mode, maybe because they're administering medication, we can auto escalate that because we have more context around what else is happening that's outside that nurse call system. So we can handle it either way, but there are definitely some advantages to consolidating all of the intelligence into one system, because then it's more aware of everything that's going on.
Okay. Another question is, can Engage use staff assignment information from Epic treatment team?
Sure. So I'll go ahead. I can answer this one. And so the answer is yes. We can both source the information from Epic. So as we understand, which users are in which roles, we can also sync information back to Epic as well. So if you make a change in our system, then we can write that change back into the Epic system as well. Then we also find that there are some hospitals that have roles for the care team that don't exist within Epic and their definition of what a care team is. And so you can almost think of us sourcing all of the roles from Epic, but then even having some additional roles that are members of the care team that only exist in our side because they're not in Epic. So we can handle it a variety of different ways.
Okay. And the next question is, can Engage manage on-call schedules? And if so, how?
Rochelle, I'll let you take this one.
Sure. Yes. So we have a variety of different integrations with different on-call vendors, particularly like QGenda or Telco. And we do it very similar to a nurse call integration, except instead of pulling alerts and alarms, we're pulling who's working and what time they're working from and mapping that into, let's say, an on-call cardiologist group. So we can source that information. I have different customers that we've worked with that may have 3 different on-call vendors for their different physicians. And so the goal is to pull all that information together, just like we do for an alert or an alarm, but make a master directory so that as a clinician or a nurse on the floor, I'm not having to go to 3 different places to see the QGenda schedule or, who's on for this group today, because they, might write it on paper and someone else might put it in Epic. So we're able to pull all of that together into one master directory.
Okay. Someone asks, what are the most common integrations that customers tend to implement?
Rochelle, what do you think? I know certainly one of them is integrating with the electronic healthcare record system. So again, you can start to source that patient data and context. But once you've done that, what's the next one that we see customers typically going for?
I think the number one thing is nurse call. I think because everyone wants to get that patient phone call or that patient request to the care team as quickly as possible. But we're seeing a lot more of wanting to use those filters to do the cardiac monitoring alarms or ventilator alarms. We even recently have integrated with IV pumps because in the past those have only been able to alarm locally. And so this actually gets that alarm to the different clinicians. So really there is a lot of different opportunities. It just kind of depends on what workflow issues your clinicians are looking to solve.
Yeah, that second one, Rochelle, that's one that I know I've seen a lot lately in the pandemic. And when you have systems that may alarm locally, in the past when everyone's door has been open, you've been able to hear those alarms even if you're not in the room. But as they close those doors, either because you're in isolation or maybe a hospital has implemented more of a quiet hospital type policy, suddenly those monitors that are alarming in the room, you can't hear them when you're outside of the room, or you may not be at the nurse's station, or you may not even have a nurse's station if you're a more modern hospital. So the ability to mobilize those alarms becomes really advantageous.
Yeah, no, one of the CNO I used to work with, his biggest pet peeve was that the alarm would be alarming at the patient's head, whatever the alarm was, and they would have to call and tell you as a clinician. And so this interoperability and intelligent workflow engine can take that responsibility away from the patient so that they can focus on healing and we can make that environment quieter for them, but that the alarms and the necessary information the clinicians needs are still ending up on their phones or their devices.
Dave, you may have touched on this a little bit, but someone asked, can you share some of the standard protocols that the intelligent rules engine uses?
Yeah, I'd say HL7 is probably one of the biggest ones. That's how we integrate with most of the electronic healthcare record systems, whether we're doing things like ADT feeds or even back to a previous question around common integrations. Another one is to try to get better use out of your EHR is to help mobilize some of the notifications coming from that EHR. And so, doing things like stat med orders or critical lab results or things like that, when those are available in the EHR, we can get those off of the HL7 feed as well. The most common protocol for sending alarms to another system is WCTP, old paging, two-way paging. A protocol, but it's sort of the de facto standard that's out there right now. SIP and TAP on the telephony side, especially as we integrate with nurse call systems. And then even when there's pseudo-proprietary protocols, web services and REST end up becoming kind of the standard sort of a data protocol, even if the payloads are proprietary and the messages are proprietary. At least a lot of folks are leveraging web services lately, which makes it easier for developers to integrate with these systems.
Well, here's a follow-on to that one. It's, can Engage work with other middleware software like Mirth, Rhapsody, and CorePoint?
Rochelle, I'll let you handle this one.
Sure. I think Dave kind of touched on this a little bit when we talked about Roland owning the escalations. It just kind of depends on what the purpose of the other middleware is. We always will send the data and interoperate, and we do integrate with those. We don't like to insert points of failure, so I'm hesitant to put, let's say, CorePoint in between a cardiac monitor and the intelligent rules engine, because it's a point of failure, and it's also could be a delay in getting that information to the right person at the right time. But a lot of times we do integrate with, let's say, CorePoint before we go into the EHR to publish assignments and items like that. So it really just depends on what the IT team is looking for and the use case for integrating with those different middlewares.
Okay, well, guys, I think that's all the questions we have today. Do you guys have any closing comments before we wrap up?
I guess I would just, go ahead, Rochelle.
I was just going to say thank you for everybody's time, and we look forward to working on some of those workflow challenges.
Yeah, I appreciate it as well. I know everyone's busy. There's a lot going on right now, and taking the time out to watch this, whether you're watching us live or whether or not you're catching this as a recording, we really appreciate you taking the time.
Okay, well, Dave and Rochelle, thank you so much for the presentation. It was really interesting. And we want to thank Vocera for making today's programs possible. We want to thank the audience for joining us. We hope you'll join us in the future for another healthcare innovation webinar. So that concludes today's presentation. Thank you.